you. Good evening. I am Nini Munoz, and I'm going to be your moderator tonight, and we have a really exciting program. So as many parts of the world have started to open back again, or at least they're attempting to, new questions are starting to emerge in as far as what our new normal might look like, and how do we integrate the lessons of the COVID-19 pandemic to prevent future ones? And the real question has become, has the sprint to develop adequate testing, treatments, COVID vaccines, and containment efforts now become a marathon of the long-lasting effects of this pandemic, as well as the efforts in the healthcare space? More specifically, what tools can we leverage in health tech to help us navigate our post-pandemic world? I'm going to go ahead and share my screen. And we'll go ahead and get started. So it's been about a year and a half since the first cases were first reported in Wuhan. Since then, the US has experienced close to 600,000 deaths, and worldwide we're over 3.8 million. As of today, roughly 55% of adults in the US have been fully vaccinated. Now, as immunization uptake increases across many parts of the country, and we transition from what we call the acute phase of the pandemic to perhaps a new level of normalcy, we face a different challenge that I would really like to bring your attention to in this discussion. Really a shifting healthcare landscape that we will continue to deal with for many years to come, as well as the question of how to lift restrictions safely, all while navigating potentially further outbreaks, emerging variants that could also threaten the economic efforts for recovery. So things are looking better. We could see somewhat of a light at the end of the tunnel, but if you zoom in and take a look at the county and state level, a very different picture emerges. While we have 55% of the adults fully vaccinated, we see that there are still small pockets of communities with higher levels of vaccine hesitancy and less accessibility to immunization. And these communities still remain very vulnerable to a SARS-CoV-2 infection. The SARS-CoV-2 virus has also resulted in an unforeseen consequence, and that is that of long haulers, a long trail of them, in fact. It is estimated that roughly 10% of those infected will continue to have symptoms many, many months after they've cleared an infection. And they will certainly continue to redefine healthcare outcomes and set new demands for the health tech space, which is what we're going to be discussing today. They certainly present a new challenge to the fields of medicine, immunology, and infectious disease. And long haul symptoms truly have cost and consequences, not just in healthcare, but also healthcare cost, productivity, and life expectancy. Let's go back. Lastly, I really want to bring attention to the inequities that exist across the globe in as far as vaccine administration. To this date, less than 1% of the population in low-income countries has received at least one dose. And we know just from taking a look at the last year that more transmissible variants have already emerged and will continue to emerge in areas where there's low vaccination uptake and a lot of transmission. So any action plan must really consider the implications of the slower progress in these nations in terms of new variants and travel considerations. Okay, so we got a great lineup of panelists today. First coming up, we have Jessica Malati Rivera, and she is an infectious disease epidemiologist who was working for the COVID tracking project by the Atlantic. Now, Jessica is not with us today because she had some travel issues, but she has kindly pre-recorded for remarks. And so we're really, really excited to have us. Unfortunately, she won't be joining us as part of the Q&A. Dr. Joseph Osmundson, he holds a PhD in molecular biophysics, and he's currently a clinical assistant professor of biology at NYU. In 2020, he organized the COVID-19 working group in New York, and he's a scientific advisor to the Treatment Action Group that really specializes in diagnostic treatments, drug and vaccine pipeline development. And he will be filling us on a key topic, and that is the one of variants. I'm sure that we've all lost track of all the different variants. And so he will be discussing what this means, how the virus may evolve, and what that means for our current vaccines. And then we're going to shift to the health tech space. Our next speaker, Justin Belante, he's the founder and president and chief operating officer of BioIQ, located right here in Santa Barbara. And BioIQ really responded very swiftly as COVID-19 exploded over the last year with their diagnostics. Justin really has used his engineering background to innovate within the healthcare system with the focus of making it accessible to millions of people and be able to navigate it. And lastly, we have the pleasure of having Dr. Yulun Wang. Dr. Yulun Wang founded InTouch Health in Santa Barbara, and he served as the chairman and CEO until it was recently acquired. So InTouch was the pioneering and market-leading telehealth company, and we've really seen the role of telehealth been cemented over the last year over the course of the pandemic, and it played a pivotal role in expanding healthcare access for many patients while reducing disease exposure for staff and patients, and primarily preserving the scarce protection equipment that was so scarce at the beginning of the pandemic, as well as really reducing the patient demand on the facilities. Prior to InTouch, Dr. Wang founded Computer Motion, a surgical robotics company that was sold to Intuitive Surgical. Okay, so since we have a Q&A to follow, I just want to remind you to use the Q&A tool that you see below on your screen to submit your questions, and we'll gladly take those for the moderated Q&A afterwards. And I really do hope that you all enjoy our program today.
Hi, everyone. My name is Jessica Malati Rivera. I'm an infectious disease epidemiologist, and I'm the science communication lead for the COVID tracking project at The Atlantic. For the last year, I have helped with the COVID tracking project's effort to collect all of the state testing, cases, hospitalization, death, long-term care facility, race and ethnicity data for COVID-19 in all 56 states and jurisdictions in the United States. It has been the honor of a lifetime to do that work, and I am actually really sad to be missing this live event to share in real time my thoughts on this very, very important topic. One that is very dear to my work and will be a kind of constant priority and focus of my work to come as we kind of pivot in this next phase of the pandemic. I just want to start by saying that as we are seeing cases decline in the United States, it's incredibly important to acknowledge the fact that the pandemic is not over. This pandemic is very much that, a pandemic. It is affecting the entire globe, and it is affecting the globe at different rates and at different burdens based on resources, based on testing capacity and utilization, based on a number of factors, access to vaccines and equity in the distribution of those vaccines. There's just a number of issues that complicate this. And so when we kind of get excited about this next frontier, at least for the United States, as herd immunity seems closer and closer, and as things begin to open up and mandates begin to get lifted, I just want to acknowledge the fact that what we might actually be transitioning into is more of a kind of living with COVID-19 in our population. We could possibly see this virus becoming endemic, which would not be that surprising. If we think back at what happened in 2009 with the H1N1 pandemic, that virus became endemic. It is a circulating virus, and it's not that surprising. It's something that after vaccines and herd immunity being established becomes less and less disruptive to our population. But acknowledging the fact that this is not a moment, that achieving herd immunity or the pandemic being declared isn't even something we could predict with any sort of certainty on a date or in a certain amount of months. I think we are getting closer each day to that, but it's important to kind of think of a mental image of a dimmer switch instead of an on-off switch, that as each person gets vaccinated, as each person becomes less likely to get sick or spread the virus, we are slowly dimming the light on COVID-19, the disease, and hopefully eventually we can look back on this and say that we beat it. There are some key concerns, though, as we move to the future, especially when it comes to data. Data has been my life for the last year. I have been in all of the kind of versions of the data, formats of the data, and it's very, very taxing to be thinking about kind of what's ahead of us, as many things have not changed. From the very beginning of the pandemic, we've just never tested enough. The COVID tracking project started with 2 journalists from The Atlantic who were just looking for testing data. They wanted to find a single resource that had reliable and complete testing data for 56 states and jurisdictions, and they couldn't find it. So they started a spreadsheet, literally started a spreadsheet to collect testing data manually from state public health departments. Eventually, we realized that this data just wasn't being aggregated anywhere on a federal resource. And so we continued with testing and cases and hospitalizations and deaths, and then got even more granular when it came to demographic data. We are in a similar situation right now in this next iteration of data collection. We are not seeing the kind of granularity of data that we need for not just diagnostic testing, but genomic sequencing. The United States is doing a terrible job when it comes to the appropriate rate of sequencing of the number of samples that we're collecting from the CDC and from other sources. And as a result, we don't have a full picture of the kind of extent to which the variants are spreading, the extent to which the variants are mutating, or the extent to which vaccines either are durable or not. Now, we have a lot of data. I don't want to cast any doubt or concerns on the vaccine durability. We have great data to show that the vaccines are incredibly effective at preventing the most important things, severe disease and death, even with the variants. However, as the variants continue to mutate, we need more data. We need more data to understand truly the incidence of breakthrough cases. Right now, what we've seen from the data is that 0.1% of fully vaccinated people could have a breakthrough case or have had a breakthrough case of infection. That's a really great probability when you think about the sheer numbers of people being vaccinated and the risk of that happening after being fully vaccinated. But again, that data is only as good as the data that we collect. And we have a long way to go when it comes to getting really good granular data, especially in populations in which there's not full coverage for vaccines and there are still cases that are being reported. Another thing that is really kind of on my mind is what this means for future containment and future data collection and data standards. One of the things that was really frustrating about this pandemic was the fact that the federal government didn't provide standards on how to report this data and how to collect this data, how to analyze it, how to talk about it. I am also a science communicator, and it's been very obvious since the beginning of the pandemic that science communication has been an afterthought for many of the public health initiatives that have happened either from the federal level or from the state level. And if we continue to do that, we will then have double the work to not only communicate the science, but to rebuild the trust that continues to be eroded with a lack of clear communication. One of the things that has been kind of failed at in communication is understanding, what are we measuring? What are the severe things that we're measuring? Oftentimes people make the conclusion that death is the only outcome that is to be feared, that death is the worst outcome. Of course, it's a terrible outcome, but there are so many other outcomes that are somewhat known and some unknown as to the extent of this really cruel virus. The impact of long hauler syndrome, or PASC as we are calling it now, is not quite even measured yet. And it's really daunting in the fact that because we're seeing a number of asymptomatic people, previously asymptomatic people, come up with issues of myocarditis later down the road, or pediatric cases of PASC. It has major implications beyond mortality. The morbidity factor for COVID-19 is huge, and it has a lot of implications on healthcare, how we manage healthcare for pre-existing conditions, which leads into the conversation of what this means for insurance companies. How are insurance companies going to manage people who were knowingly previously infected or unknowingly previously infected? How do we determine what these underlying conditions are that make them have a greater proclivity to other complications. There are so many unknowns. And again, the simple answer, in my opinion, is better data. If we had better data, so many of these things could be better answered, or at least better prepared for. Now, how is it that insurance companies are going to create policies that allow for this? I'm not really sure, but I think that the conversation needs to start with providers. I think that providers need to be talking to their patients and public health departments to figure out what can be determined as a pre-existing condition. And will we consider COVID-19, because of its global nature and disruptiveness, something that is kind of an exception to the rule when it comes to conditions? Now, as we move forward again in understanding the impact of this disease on our society, as we are seeing more and more people get vaccinated, I am very troubled and often, kept up at night thinking about the fact that we are often responding to this pandemic in a very insular way, with a focus on your current condition, your current place of residence. The US is probably going to beat many countries when it comes to achieving those north of 70% of the population vaccinated rates. Does that mean the pandemic can be declared over in the United States? No. The best way, the most effective way out of this pandemic is through mass vaccination. And mass vaccination in its truest form is the best way to achieve things like herd immunity. There aren't any other ways to kind of calculate that. But vaccine equity continues to be an ongoing issue when it comes to how do we get past this? How do we move forward in this pandemic, in this next phase? Now, today, I'm speaking to you on Monday. I was very encouraged to see this wonderful data coming out of Novavax that is 90% effective at preventing severe illness and 100% effective at preventing death, which is really great outcomes. That's exactly what you want to see from vaccines. But the most exciting part of that is knowing that the US doesn't need those vaccines, which opens up the opportunity for more donations, and it opens up the opportunity for COVAX to commit to 1.1 billion doses of Novavax to distribute to more in need countries. Now, when it comes to achieving these immunization goals, some of the predictions right now, some of the estimates right now are showing that some countries will not be fully vaccinated until well into 2023. That is entirely unacceptable, especially when we think about how diseases are globalized. They're globalized through transit, through mass transit, people getting on planes and boats and cruise ships and all kinds of ways to kind of be connected. And that stuff is opening up again. The US has made it clear that if you're traveling domestically, it's relatively safe for you to travel without needing to do things like testing and quarantine. But international travel is going to be requiring things like that. Not to mention, a number of countries are requiring proof of immunization in addition to negative testing. Now, we are still going to have to consider the fact that the different pace at which countries are achieving fully vaccinated statuses for their populations are going to be very kind of inconsistent because of the issue of vaccine equity and vaccine access. When we think about the vaccine process, right? It's more than just the manufacturing and distribution of them. It's that last mile of vaccines. We often say that vaccines don't save lives, vaccinations do. So getting it across that process through the cold chain so that it has that proper storage throughout and stays fresh up until the moment of immunization, that's when you can actually see the gaps in vaccine equity being closed, when it's considering that full mile. And in that full mile is a lot of communication. I mean, I'm going to harp on this because I'm a communicator and I've been working on this space and in the vaccine space for many years. And I have seen the impact of doubt and misinformation and disinformation and conspiracy theories on how people respond to innovations like this. And so when we talk about ways to get to the end of this marathon, as we're calling it, not the sprint, this marathon, so much of it is about enduring communications that's also tailored to very unique groups. There's not a one size fit all when it comes to communication about this. It needs to be culturally competent. It needs to be emotionally intelligent. It needs to be accessible based on all kinds of abilities and limitations, whether it's internet speed or language or simple language. One of the things that I often say too is that I feel like the work of science is not done until it's communicated. And so the work of getting through this pandemic isn't either, but it has to be done appropriately because we're not in a sprint anymore. We are absolutely in a marathon. And this marathon is giving our our body, our collective body, the kind of strength training we need for the next one. And yes, I do mean next one. This pandemic for many of us in the emerging infectious disease community was no surprise. It was always a matter of when, not if. Another pandemic will happen. And I am very hopeful that our preparation when it comes to data infrastructure, communication, testing for diagnostics, testing for sequencing, testing for understanding the scope of variants and vaccine durability will be all of the ways in which our toolkit is being refilled, right? In many ways, our toolkit had been emptied by the systematic defunding and devaluing and deprioritization of public health. And until we kind of fill that toolkit again with all of these tools, with this very renaissance collaboration from people from all kinds of disciplines, including healthcare, including insurance providers, it's going to be very, very difficult and once again catch us by surprise. There are many ways in which we can find indicators and warnings of something as disruptive as a emerging pathogen that could cause a pandemic. And it's now starting again. I'm part of some research that is happening with a very wonderful collaboration from all kinds of tech companies and research groups that are trying their best right now to have a system in place that can track the emergence of threats that could turn into emerging pandemics. That's the kind of research that did exist. That's what got me into this space. I was in that space for many years ago at Georgetown, working on research that was funded by the Department of Defense, because the Defense Department is very interested in understanding what emerging threats of biological nature, naturally occurring and not naturally occurring, can be for our country. And so that said, there are so many kind of ways in which we can be prepared for the next one, including how we prepare ourselves as a community. To understand that things like masking and things like physical distancing and things like vaccines are not moments in time, right? There will be a time in which masks will not be necessary forever. But I also think one of the takeaways, and we can look at history to even teach us this, when we think about the 1918 pandemic, one of the greatest takeaways of public health was the prioritization of hand washing and hand hygiene. From this pandemic, we're seeing this incredible importance of things like masking. Masking has been known and has been proven through countless studies to reduce your risk of getting COVID-19. And I think for many people, that muscle memory and even that comfort of wearing a mask will go on past the pandemic, during flu season, during times in which they're traveling, if they've got a tickle in their throat and they feel a little bit under the weather. I think that is one of the silver linings of this experience, that we are learning to adapt and understand that we are so connected, that all of these things keep us on our toes to respond in altruism, to know that our decisions don't affect just ourselves, that our decisions affect our community. In fact, one of the earliest criticisms of the vaccines from many of the anti-vax community were saying that the vaccine didn't even stop transmission. Well, it absolutely does. And that's why we can confidently say that the vaccines not only protect you, but they protect people around you. And one of the ways in which I think we can all be pushing towards better preparedness for the next pandemic and crossing this finish line, this kind of metaphorical finish line of COVID-19, is asking our representatives, asking our government to do more when it comes to prioritizing public health, to encouraging them to funding this work and funding research groups that are doing very expensive and tedious work involved with diagnostic and sequencing, and understanding that containment can only happen if we have good data. And this data should not be relied upon or should not be aggregated and provided by volunteer organizations. They should be provided by the federal government. We stopped data collection on March 7th because we felt very much that our work was always intended to be temporary and that this was the scope of the federal government. And so I'm hopeful that between the private sector and the government sector, that we can work together to hopefully in the near future get to a place where if we think about an emerging infectious disease outbreak, we have our toolkit full of all kinds of resources to prepare. Again, I'm so thankful for the opportunity to speak to you all, and I wish I could be there in person so that I can enjoy a lively conversation and discussion. But I hope that you find my thoughts to be more encouraging than discouraging. I have often erred on the side of cautious optimism, but I will say that each day I feel more and more confident that we are going to be much better prepared for the next one. Thank you again. Take care. Bye-bye.
Great. Thanks so much to Jessica for that. And we're going to head on to Dr. Osmundson. And I think that discussion about vaccine inequity inarguably leads us into the discussion about variants. Go ahead, Joe.
Great. Can you hear me and see me, everybody? Well, I can't see the chat anymore, so what does it matter? Let me bring the chat back up so that I can tell if you can't see me or hear me. I have, what I'm going to talk about is very similar to what Jessica talked about, just through another angle, but our messages are quite similar. I do think I will, by the end of this, have an answer to this question of, has the marathon turned into a sprint? And I'm going to be talking about the emergence of variants, how we prevent them, where they come from. And as a molecular biologist, this is my favorite type of thing to talk about, because we can get all the way down to the level of molecules. And I will say that in terms of the science of understanding viral evolution with COVID-19, we're relying on decades of research and technologies that have been developed in the last decade. And we're relying on decades of research into previous both pandemic and endemic coronaviruses that have been studied by research labs. And without that, like I was talking before this about what our response would have been in 2003 if SARS-CoV-1 had been able to reach the pandemic scale, and we would be so far behind where we are now. So I'm going to show you some primary data. I know you've all seen this picture on the left of SARS-CoV-2. That's the virus that causes COVID-19. This image is based on a couple of real life pieces of data, both from a technique called electron microscopy, where we can actually see viruses if we bombard them with high energy electrons and look at those electrons on a piece of film. So coronaviruses are named because they look like a crown under what's called a transmission electron micrograph. And that type of image is used to create this type of representation. And then this triangle shaped red protein that you see on the surface of this virus, just to blow your minds really quickly, anytime you see colors represented on a virus like this, that is what we call pseudocoloring, because color literally doesn't exist on the size scale of viruses. Viruses are about 10-fold smaller than the wavelengths of light that produce color. These are colored red because they're a very important protein. It's called the spike protein. And it is through this protein that the virus is able to attach to our cells by binding to a cellular protein in our bodies called ACE2. So I'll be coming back to that in the end, okay? I want to talk briefly about what RNA viruses are, and I'm going to get a little bit in the molecular biology weeds, but I promise it's for a reason. All cellular organisms, from bacteria to us, store our information in the molecule known as DNA. It's double helical. It's very, very stable in cells. That information is accessed by making a molecule of RNA. RNA in our cells is not very stable, as a half-life on the order of minutes or hours, and it's degraded over time. There are no exceptions in living organisms to this fact, right? So we actually call this the central dogma of molecular biology. DNA is stored, or information is stored in DNA, accessed in RNA, and usually function comes from the protein that's encoded in that RNA. You can think about this like a computer, DNA holding information, mRNA being the sort of RAM that is able to do computation and access that information, and the protein itself being a computer program that's able to perform a function. Coronaviruses and other RNA viruses obliterate this rule altogether, and that makes them unique in the world of the biological sciences. Coronaviruses encode their genetic information in the molecule that is RNA, which is one of the reasons why they're so easy to wash off our hands and off of surfaces. Okay, so in general, viruses break all of the rules of life all of the time, and how they act in our bodies and how they act epidemiologically relate to their molecular biology. And that I find really both fascinating and powerful. The molecular biologists can tell us a lot about how a virus is going to act. And if we think about these molecules of life, DNA and RNA, if you think about it, you can have a virus that does it, right? So there are viruses that have single-stranded RNA as their genome, and double-stranded RNA, single-stranded DNA, and double-stranded DNA. And coronaviruses are a family of viruses that encode their genetic material in one strand of RNA. Some other viruses that do this are influenza and HIV. Okay, I can see the chat. If folks have questions, please feel free during the talk. Coronaviruses are unique in all of RNA viruses. They are huge in terms of their genome. So a genome is just a string of letters of DNA or RNA information. Both DNA and RNA have 4 bases that are possible to encode information, and each position from 1 to however many will be one of those 4 letters, okay? Most RNA viruses are between 5 and 15,000. So if we think about things like HIV, it's 13 or 14,000 letters. Flu is around 10,000 letters. Coronaviruses, if we map the size of the genomes of all of these different RNA viruses, are an absolute outlier at around 30,000 bases of information, okay? This actually really restricts how quickly they evolve. Okay. So like I said, coronavirus is an RNA virus. It's enveloped as well. It gets into the cell and gets out of the cell without ever encoding its information in the cell, okay? So unlike a virus like HIV, which is a different RNA virus, HIV gets into the cell, transfers its information into DNA, and like the infection of HIV will stay with that person for the rest of their life, right? Because that information becomes encoded in our actual DNA. Coronaviruses and influenza are what we call acute infections. The RNA in the coronavirus never becomes DNA, so it never sticks around. The infection tends to last around 10 days from the point of getting sick to where the virus stops being able to transmit, okay? And the process through which a virus copies its genetic information is crucial to how fast it evolves. Right? I'm gonna say it's so important, I'm gonna say that again. The process through which a virus copies its information is critical to how fast that virus can evolve, okay? RNA viruses are sloppy when it comes to copying their genes, okay? If I have 3.2 billion bases of DNA in my cells, my cells have to be very careful about not making mistakes when they copy those 3.2 billion bases. Otherwise, I wouldn't make it to the age of 10 or I would be a walking cancer. Viruses tend to have a lot more mutations than cellular organisms, and RNA viruses in particular have very sloppy machineries to copy their genetic material. Most mutations are bad or do nothing, but some mutations can be beneficial. So the more the total number of mutations exist in a virus or organism, the more possibility there is for evolving new what we call phenotypes or functions, okay? Again, because of decades of research on coronaviruses, we actually have structural information. So this is a protein structure. This is the world that I live in, where in 3-dimensional space, we can place every non-hydrogen atom in this viral protein in space. We know what it looks like. This is the starting point also for how we design drugs, because drugs are typically small molecules that will be able to get into this protein and mess up its function. Okay, so SARS-CoV-2 hits, we already know, because it's a coronavirus, what machinery it uses to copy its genetic information. And unlike any other RNA virus that I can think of, at least, I'm sure there are others out there waiting to be found out, its machinery that it uses to copy its genetic information has an error checking domain. Like, so my machinery doesn't want to make mistakes. And there's a domain where if a mistake is made, it can come in and cleave out that mistake, try again. And that makes it orders of magnitude higher in fidelity. Fidelity means fewer mistakes, right? So here is the gene. This XON means an exonuclease. That's fancy words for air checking domain. Here is the machinery that takes one strand of RNA of the virus and makes another strand to copy it. And you can see this protein is called NSP14 and it sits right here. If the virus makes a mistake, blammo, it can come in and correct it. SARS-CoV-2 mutates much, much less fast than influenza, than HIV. Okay. That all, from the variance point of view, should be good news. Right? The more mutations there are, the more variants there will be, the faster the virus can evolve. I would say for about 6 or 9 months after the emergence of this virus, we felt like the evolution of the virus was one of the things on our side. I'm going to show you where these data come from. But basically what we can do is we can take a virus from a patient sample and determine every letter in that 30,000 letters that make up the genome, and just count the number of differences between viruses. The more differences, the more, the further divergent those viruses are from one another, and the more possibility for evolution. And what we saw over time is that this virus doesn't evolve really that much at all. Kind of no matter how many cases we saw in the world, we thought that over time, over about 12 months, so over about a year, we would see about 25 to 30 mutations, difference between any two viruses, no matter how far apart they had evolved. So we were like, oh, okay, this is great. This is chill. SARS-CoV-2 is SARS-CoV-2 is SARS-CoV-2. We're not super worried about evolution. Until we started to look more carefully and notice that there are some of these viruses that just rack up mutations. Okay, so again, the y-axis is the number of mutations, the x-axis is time. All these viruses are hanging out down here, but a select few will just develop tons and tons of mutations. Where these come from, we think, is from individuals who are so immunosuppressed by things like cancer, so their immune systems are so low, that whereas most people clear all infectious SARS-CoV-2 in 10 days, these people can be infectious for months. And so the virus has lots of time to evolve within an individual. So we think this evolution happens within individuals instead of between them necessarily. Here's a case study of a patient who tests positive for SARS-CoV-2. This patient was hospitalized for cancer and tested positive for SARS-CoV-2, not just for the diagnostic test for the RNA, but actually for culturable live virus for 70 days after their initial infection. Okay. The variants that we talk about tend to be in this protein called the spike protein that determines how well the virus binds to our cells. The first question, okay, we see these mutations coming up. Are they more transmissible? We had sort of seen a false flag with this mutation called D618G, where some scientists claim it was, and others said no. Epidemiological data is very noisy, so it was hard to tell. But we started to see data like this with the first variant, now called alpha, where in a population over time, if you sequence all of the viruses, the proportion of that variant goes up and up and up. That's troubling. And if you see it in one place, that could be explained by other evolutionary phenomena. But if you see it over and over and over again, you really start to worry. So that's what we started to see late last fall with the variants. And I just want to show you again to connect to primary data where these come from. So if we have just a diagnostic test for SARS-CoV-2, that is actually looking for, by a method called qPCR, the virus's RNA in a patient sample. A healthy patient should not have viral RNA hanging out in their nose. Someone infected with the virus will. The nice thing about this is this very same sample can be put into what's called an Illumina sequencer, and we can actually determine all 30,000 bases in the genome of the virus, okay? And then by this is gonna look really complex, but we're gonna get to the data. By comparing those letters, we can determine what viruses are related to what. So this is a paper that does that. These data themselves are just letters, right? C's, A's, G's, and T's. Those are the 4 possibilities for DNA sequences. And if we compare these 3 viruses, they're all from Washington. You might assume, well, 3 viruses from Washington are all going to be related. But if you notice, these 2 viruses from Washington are all missing these particular bases. And so those 2 are probably related, but it's not necessarily related to this last RNA virus, this last Washington virus that has those 3 bases and is missing these other bases, right? So depending on the presence or absence of insertions and deletions and mutations, you can actually trace the evolutionary heritage of the virus. And that's precisely what these analyses do. All right, that's the background where these data come from. These variants are definitely more transmissible. And now it's like every time that a new variant comes out, it's like, oh God, another one. How are we going to understand this one? What is it doing? And if you notice that alpha variant that spread through the UK last fall, it is now being beat by a new variant, this Delta variant. Okay, and so this is looking in Scotland. You can see Delta is beating alpha over time. It's probably more transmissible. And it turns out all epi data show that it definitely is. Just to highlight what Jessica said, these data are from Scotland, not from the US. We need genome sequences from the viruses to be able to do these analyses. We are not doing enough of them in America. The UK and Scotland are doing much, much better. The million-dollar question, do these variants escape vaccination? Okay. Early data showed that there's a clear difference in the immune response with these variants. On the y-axis, I'm basically showing you a large number is a very good reaction of the immune system, and a low number is a lower reaction. So if we looked at these early variants, this is alpha, you see that after vaccination, you still have a really, really nice response. Okay, I'm just showing you better data, more recent data. And this is the troubling thing we see with some variants, all right? That there appears to be a less good immune response after vaccination to some variants. Now, this isn't a test tube. This is saying how much virus is actually stopped by vaccination. The last thing I want to tell you is actual data from epidemiological studies in people. The Delta variant is the predominant variant in the UK now, and vaccines are still doing great. Okay, so this is data from patients of 7,000 cases that have been sequenced in the last 28 days. Of the number that are vaccinated, we only have 2 deaths and very few severe cases, all right? So the majority of cases and severe cases are in patients who are either unvaccinated or not yet fully vaccinated. So this is a huge argument for not just 1 shot, but 2. And the take-home message that I'll leave you, so people in the UK, because of the Delta variant, are starting to worry about a 3rd wave. The thing that I'll leave you with is this. The Delta variant is also already very troubling, definitely more transmissible, and has the possibility for evolving further to have better immune escape from vaccines. The more infections you have globally, the more viral replication you have, the more copies of the viral genome are copied, therefore the more mutations there are, therefore the more what we call evolutionary space there is to evolve variants, right? We don't want any of this. This is the dumbest slide I've ever made in my life, but the idea is so simple. The way that we stop this from happening is vaccinations. And because we're in a global community and the evolution of a virus anywhere on the planet can affect all of us on the planet, this vaccination project needs to be global. It needs to be as fast as possible. So to answer the question, pandemics are a marathon of sprints. First, we had to develop diagnostic tests as fast as possible, then a vaccine. But we are not yet protected, even by our good vaccinations here, until the globe is vaccinated because of the evolutionary space left open by any ongoing COVID-19 infections. And I'm going to leave it there.
Thank you so much for that. And with that, I'm going to hand it off to Justin Belante.
Thank you, Nini. I'm going to pull up my presentation. Thank you, Dr. Osmundson. You summarized about 100 hours of reading over the last 6 months. Wish we would have talked a few months ago. I'm going to share my screen here. Get that in presentation mode. All right. Bring my chat up as well. Cool. I hope everyone can see my screen. I'll go ahead and get started. It's really an honor to chat today. I'm the co-founder and president of BioIQ. I'll start off just really quickly. Who is BioIQ? This is actually a slide from our pitch deck in 2005. BioIQ started in Santa Barbara. I started out of grad school in UC Santa Barbara. And the original model for BioIQ in 2005 is we wanted to be Netflix for healthcare. We saw what Netflix was doing to the consumerization of movies and entertainment. And we saw a real lack of consumerization and access in healthcare. And so similar to the way that Netflix sent DVDs to people's homes, we wanted to send diagnostic test kits into people's homes, have them prick their finger, put a couple drops of blood or a urine or saliva sample, drop that in the mail. That would go to our network of labs across the country. They would process those, and then we would bring those results online and help people manage and track their health profile, similar to the way that they could manage their movie preferences or their finances. That was the original model. maybe about 12 blocks up from where the MIT Venture Forum is usually held on the 1200 block of State Street. That's where we started. But it has been a journey since then. Over the last 15 years, we took that direct-to-consumer home diagnostic model and pivoted into working with employers. We use this to help employers test and screen their populations for heart disease, diabetes, and other types of conditions. We did about 10,000 health screening programs for employers before expanding to working with health plans. And as we now work with over 40 health plans, those plans represent about 70% of all the insured lives in the US. And a big part of that focus is really engaging populations, specifically around Medicare, Medicaid, or commercial populations, engaging them, getting their attention, and letting them know that they need to test for certain conditions every year, for cancer, diabetes, heart disease, chronic kidney disease, other infectious diseases. So as you can think about it, we had a technology platform to engage and test populations. When COVID hit, we really found ourselves in a position to do a lot of good. What we didn't know at the time is anything about infectious disease or pandemics. And so we put together an advisory board early on, one of whom was Dr. Regina Benjamin, former US Surgeon General. We brought on a member of Operation Warp Speed, Tom Corey, former CMS Director of Communication, as well as a number of public health officials, epidemiologists, so we could really get up to speed on how do we use this platform of engaging and testing people at scale, how do we use this to help with COVID? And in particular, early on in COVID, as Jessica mentioned in her talk, the last mile was a real challenge with testing. What we saw is actually there were a lot of labs across the country, research labs, hospital labs that were developing testing, but there's a real challenge in getting testing to individuals. And so we went to work. And the way that we approached COVID in populations early on, with a big focus initially on employer populations, because we work with employers, as well as government populations, as we used the South Korea protocol. If you all remember that early on in the pandemic, everyone found it to be very successful if we could screen people for symptoms, test those who are symptomatic. If they're positive, we can do contact tracing, we can isolate those people as well. And that was really a way of really curbing the spread of the pandemic. So that's what we applied to employer populations and government populations. However, that protocol in and of itself would change a little bit. For instance, if we applied that protocol to nurses going into a nursing home early on in the pandemic, that cadence of testing, the protocol was much more intense. We were testing daily or every other day because the risk of somebody going into that population with an infection was very high. On the other end of the extreme, we worked with technology companies where people could mostly work from home. And so, the testing regimen in those populations was a lot lighter. And then if you think about the middle of that spectrum, working with companies, employees that had to go into manufacturing jobs, retail or other locations, then that protocol or that cadence of testing was somewhere in the middle. So we took that protocol and first we went into populations and started tuning the intensity. And early on, we worked with critical infrastructure, healthcare workers. We worked with some of the largest food processing companies in the United States and world, as there were a lot of concern about food shortages. That expanded to manufacturing, and we'll talk about some of the other expansion. But one of the first questions we had to answer, if you all remember, was, well, what type of test do I use? And early on, there was a lot of debate around RT-PCR, which tests for, do you have the virus, as Dr. Osmundson talked about, versus antibody testing, which means, did your body produce antibodies? And maybe that's evidence that you had it in the past. And so generally everybody, especially on the diagnostic side, really centered on RT-PCR testing as the gold standard. This really tells you, do you have the virus? And then the next thing everybody had to figure out is, well, when is the best time to test? Because you may have the virus, but you have very low viral loads or evidence of that right after you get symptoms versus 3, 5, 7, 14 days later. And so we had to take these protocols and populations around when somebody gets symptoms, what do you test them with, RT-PCR, and when do you test them in this window so that we can optimize the ability to actually detect somebody who is positive. Now you can see the type of test has evolved quite a bit. This is a website from Harvard who's done a great job of looking at all the nucleic acid tests. These are tests that are actually looking for the virus RNA versus your protein tests. Those are antigen tests, and they look for proteins associated with the virus. Generally, as we've seen, the nucleic acid tests, or RT-PCR, are much more accurate than your antigen tests. And I use accuracy as a general lab term, not the more lab-specific terminology people use around sensitivity, specificity, positive predictive value, some of the words that we've all become maybe too familiar with over the last 12 months. And so as the pandemic began for us and we kind of shifted into how do we leverage our platform to help these populations, one of the first things we did is focus on, well, let's make testing easier. And so we worked with our lab partners to bring to market a saliva test so that people didn't have to put a swab in their nose. That's often uncomfortable, especially early on in the pandemic. A lot of people had to use a nasopharyngeal swab, so they had to put the swab all the way to the back of their nose. Really, they call it the brain tickler, or way down their throat. And so we came up with some more consumer-friendly ways of testing. Of course, we then kind of evolved, and the country evolved from testing from the nasal swab to the nostril swab to saliva. Testing then evolved to what we now call flu-vid testing, especially as we went into flu season last year. People became concerned about, well, if I'm sick or have symptoms, how do I know if I have the flu, common flu, or if I have SARS-CoV-2? And so we launched flu testing, and the FDA approved a series of those. Over time, earlier this year, the FDA began approving a lot of home test kits for over-the-counter use. Again, just expanding access to tests without a doctor's order. We've continued to evolve testing, and testing has evolved. We've partnered with companies like you see here who have battery-operated portable RT-PCR machines that you can actually take to work sites to conduct testing and get results, RT-PCR lab standard results in as little as 2 hours. And then, as Dr. Osmundson talked about, we've also begun reflex testing. And this is, Jessica talked about it in her talk as well. There's a real need for this in the US. We're lagging most of the world when it comes to variant testing. And so that means when we're in a lab and we test a positive sample, can we then take that sample and put it in a next-gen sequencer to figure out what type of variant that person is infected with? And as we said, there's a real need for that type of testing and ongoing testing of variants in the US. So as we went into these populations over time, as the testing has evolved, what the FDA has passed under its emergency use authorization rules, this evolution of testing from nasal swabs to saliva to expanded testing to sequencing of variants, one of the challenges was really what Jessica referred to as the last mile. How do you then get these tests that these labs and brilliant scientists have developed, how do you get it into these populations at scale? And so as we work with employers, we basically work with them under two models. One is a model where we actually send a test kit to an individual's home. They can collect their own sample via a nasal swab or saliva, drop that in the mail, and then get their results online. The other, and this is something we used in a number of different settings, would be worksite testing, where we actually bring the test or the sample collection to a worksite. And worksite testing started early on, where we would collect samples at the worksite and then send those to a lab for analysis, and people would get results in 24 hours. And that's evolved to more rapid tests. We'll talk about that in a minute. Another big part of testing in these populations was the contact tracing and notification. So it was very important to employers, whether you have a large manufacturing plant and you have people in the plant, it's likely that they weren't quite able to socially distance, and so the virus was more transmissible. So they had to test and be very careful about identifying it early. So what we do across these populations as we're testing everybody is provide a dashboard so we can track when there's a positive, we can contact that person with a clinical person, and then we can contact the other people that work around them. And in doing that, we can then take them out of the workforce for a temporary period of time. So it prevents further transmission of the virus. And that's really how you prevent a virus running through a workforce or a manufacturing plant or a food processing plant or a film production like wildfire. And so as we launch these solutions, we work with certain types of employers, Google being one of those examples mentioned here in the Wall Street Journal, where we had a lot of clients, tech companies, et cetera, that would provide this testing for their employees, most of whom were working at home. But the real concern was, I want my employees to be safe. I want them to be productive. I don't want them to get COVID. And so this was a solution that they provided to their populations. At the same time, we did a lot of worksite testing. This is also another article that was written about some of the work we did with Pinewood Studios or Trilith Studios in Atlanta, Georgia. They did Avengers Endgame, but we worked with them on a number of large productions. And that then expanded to over a dozen film and entertainment companies, where we really found an opportunity to help film and entertainment continue making movies. If you all remember, there was a little bit of a concern that there was going to be a big drop in our Netflix productions and movie releases, et cetera, because movies basically paused. New films, shows, et cetera, basically paused for a couple months at the beginning of the pandemic, when we had to kind of figure out, well, how do we get all these people onto a set, into a studio, keep them safe, so that we can produce these movies and shows. And so we did a lot of work in that space. And when we did that, this is an example of some of the worksite testing that we did early on. That testing tended to be, we would go on site, the actors, the manufacturing workers, et cetera, would come on, we would collect samples, and then we would send those to a lab. They'd be processed in 24 hours. And as testing has evolved, the thesis for COVID testing was that generally the cost of testing would go down over time, and the timing of results would also go down. And so we've seen really the emergence and continued emergence of rapid tests. And so in these large populations, we can, from a worksite perspective, we can do rapid antigen testing. That's probably the least accurate type of testing on this page, but it's good in a testing protocol if you're testing more frequently. Down from that, we could do rapid molecular testing. And those are things like using the Q test or the BD test or the Abbott test. And then below that, we have really lab standard testing, but it's done in a portable format on site. And so we've seen, as we've deployed these solutions, testing solutions in these populations around work sites, a real evolution in the type of tests that are available, and then how quickly we can now get results. So I'll pause right there, and that's kind of been our journey as we started the pandemic, thinking about how do we take this technology platform to engage and test populations and evolve it for COVID. You've seen the evolution of testing, and we've all heard about it and read about it over time, the evolution of testing with COVID. And so where do we go from here? Clearly, the work we did in the past, a lot of employers that we were testing and working with, or state governments that we were working with, those were employees that had to be in a plant, had to be on a studio, had to be in a data center or in a certain type of office, people who had to be at work. And it's interesting now because as we see in the pandemic, cases coming down, things starting to open up, now it's interesting because people are going back into the workplace. And of course, as people are back into the workplace, you create more opportunity or probability for the virus to spread. One of the things that we see driving that, this is a study that was done by Microsoft of over 30,000 people with trillions of points of data. And what they saw is that when everyone was working from home, it did two things, amongst others in a population or in a workforce, is that one, it made everyone become more siloed. You tended to talk to the people that worked in your department more than other departments. So you lost that kind of talk around the water cooler. And so that's a challenge from a productivity perspective for companies. It's a driver to get back into the workforce. And then we also lost a lot of the small talk or the things that kind of made work fun. And so as a result of that, a lot of employers want to get back into the workspace or the work sites. And so as we look at what employers are focused on moving forward, there's kind of three things that we focus on. Jessica hit on a couple of these. One is engagement, and that is making sure that we're educating populations about getting vaccines before they go back into the workplace. There's a lot of legislation now that says that employers can demand that people have vaccines to go back. The other thing we focus on is social determinants of health or health inequities. making sure that we're communicating in a culturally sensitive way. And then, of course, we're focused with these employers on providing vaccinations for their employees going back to the worksite, either COVID vaccinations, boosters that may or may not come in the fall, as well as flu vaccinations. Because if you have a bunch of people that have flu symptoms, you kind of have a bunch of people that have COVID-like symptoms. And so we want to get ahead of that. And then from a testing side, as we look to the fall and more people getting back into a workplace, we see there'll be continued kind of surveillance around COVID testing, but also other things that kind of look and feel like COVID, because you're going to want to diagnose those very quickly as well. And so that's expansion into flu, RSV, strep, and other types of testing. One other thing I'll mention, as Jessica talked about, a lot of what has kind of driven the increased testing and investment in testing is that very early on in the pandemic, CMS increased the reimbursement rate for testing. That drove a lot of more private participation in the testing market. They increased it from $60 to $100. We saw them do the same thing with requiring insurers to cover antibody tests. And we're seeing the same thing now for vaccination. Early on, CMS was reimbursing for around $45 for a full 2-dose vaccination. That's now been increased to $80. Now, these are some of the trends that have kind of propelled a lot of the innovation around testing and are pushing more people into vaccination as well. So I will pause there and get ready to hand things off to Yulin, but hopefully that's a helpful kind of walk through the journey of COVID testing for employers and populations.
Thanks so much, Justin. And with that, I will hand it off to Dr. Yulin Wang, our last panelist.
Great, thank you very much. And I've certainly enjoyed listening to the 3 speakers who have already gone. And while they were speaking, I was thinking about how I can contribute to the dialogue. And so do you see my screen, Nini? Just make sure that you see my screen and hear me. Okay, perfect. Okay, so, I think all 3 previous speakers were focused on helping the country and the world solve the COVID-19 pandemic. My talk's a little different. I'm actually going to be talking about telehealth, and I'll explain in a moment what telehealth is. But in a sense, what my talk is about how we've been able to keep our health system running, both in the U.S. and perhaps globally as well. How we could keep getting healthcare to people and patients who need it during this pandemic. And then I'm also going to talk about how then the pandemic has transitioned our healthcare system, where it's probably never going to be the same again as the way it was pre-pandemic. So I think, as Nini said, my background is I started a company called InTouch Health, which was did telemedicine, and it was actually during the actual pandemic in July of last year. My company InTouch was acquired by Teladoc Health, and so I'm actually now speaking to you from a role at Teladoc Health. And Teladoc Health is the largest virtual health company in the world, and so we have a pretty good view of what's happening in terms of enabling virtual care across the country and worldwide. But just kind of the motivation pre-pandemic, all the way back to say 2003, why did we think telehealth or virtual care was better? It's because the reason is because what's the objective? It's to be able to deliver easy to access healthcare at a consistently high quality, and to be able to do that at a lower cost. And so how does that actually occur? Well, if you have a purely brick and mortar healthcare system, or a patient or a person's got to be next to the clinician physically in order to get care, then you're very limited by the geographic and time constraints that places on healthcare delivery. And then if you especially take into account the specialization of medicine. I think we heard a lot about the specialization of medicine in the last 3 talks, specifically in the area of infectious disease, but medicine is getting specialized across all the different areas and all the different organs in the body. And these specialists are harder and harder to access because they're more and more geographically dispersed. They're basically usually in big cities, and then people, unless you live in the big city, you have a difficult time getting access to the right specialist. But if you can use virtual care or telehealth, and I'll use those terms interchangeably, and if you can equip that clinician with the right data about a patient, that clinician can not only take care of patients who are in their immediate geographic vicinity, but they can actually take care of patients wherever they exist around the world, or around the region or the country or the world. So how does that look? Well, we built a telehealth cloud effectively over the last 15, 18 years, and it's basically built on top of the internet, where what we did is put, the capability of data storage. It was good to hear Jessica and Joe talk about the importance of data. And I think one thing which is interesting about telehealth is the ability to store data naturally occurs in the telehealth kind of interaction between a clinician and a patient. And then you also have processing horsepower in that telehealth cloud, which allows you to do all kinds of things in this interaction between a clinician who's represented on the left side of the screen and a patient who's interacting with that clinician through a telemedicine device, which is represented on the right side of the screen. So what we did at InTouch, and now as part of Teladoc, is we built this telehealth cloud, and we've connected over 3,000 hospitals now globally into this telehealth cloud. I think today there's 15 to 20,000 different physicians who are connected in this cloud too. You can see some of the logos on the top and bottom of the slide in terms of the types of organizations who are connected into the cloud, and their clinicians are able to connect to the patients wherever they exist in order to render care. So telehealth was moving along, and it was actually starting to hit an inflection point of adoption maybe 3-4 years ago, where it was growing at 30-40% a year. So, from a business metric, that's very good. But then COVID hit, as we all know, last March. So March of 2020. And COVID, the term which is often said is COVID took telehealth or virtual care and accelerated in 5 months what would have taken 5 years. So I was actually just looking at an advisory board document, which is a consulting firm in the healthcare world. Back pre-pandemic, maybe 1% of the interactions between a clinician and a patient were being done virtually. And then right after the pandemic hit, so now we're talking about March, April, May of last year, the percentage of interactions that happened between clinicians and patients jumped to over 50%. So you can imagine the entire healthcare system, the $3 trillion, I'll be US centric for a second, the $3 trillion system that we have here, where it went from 1% of the interactions being a particular way to over 50% in a couple of weeks. It was chaotic is probably the best word I should use, as opposed to any kind of swear words, which were going on at the time, because our systems were breaking, to be frank, because they were not designed for that kind of load at that point in time. This area of telehealth, it started, as I said in the beginning here, to enable improved access to care, and to improved access to consistently quality care, and it can actually lower costs as well. And it was growing nicely on those value statements. But what did COVID do? It actually enabled healthcare to happen when otherwise it couldn't because of fear of infection. So the problem was that, whether you're a patient or a clinician, you actually needed to use virtual care in order to keep taking care of patients in midst of this pandemic, which, if you just remember, middle of last year, people didn't even understand, let alone a vaccine being developed. And so health systems around the country were trying to figure out, how do you basically actually keep the doctors at home, not just the patients at home? How do you keep the doctors at home in order to take care of the patients who might be at home as well? And then they, all emergency or all types of surgery and imaging and other kinds of tests were shut down. Cottage, for example, shut down all elective surgery for many, many, many months. And only emergency surgery took place, but people still got sick, people still had cancer, people still fell and needed orthopedic surgery, people still had heart attacks and strokes and stuff like that. And how do you keep the health system going? And so what had happened is, because really of a forcing function, it allowed virtual care to be tried by everybody. So, and then the other thing which happened is that there are these historic barriers of telehealth and virtual care, one being just regulatory barriers because of state licensure of clinicians. And also there are these laws called the anti-kickback and the Stark laws, which actually have present challenges to telehealth. So Congress went ahead and moved forward to eliminate those barriers. And then the other big barrier was reimbursement, and reimbursement has actually been removed. The barrier has been removed, as in a physician who now takes care of a patient via telemedicine gets paid as they would, or they'll get paid also, whereas previously they weren't getting paid. Whereas if a patient came into that physician's office, they get paid. So these are the things which COVID drove front and center and made happen. And so now that's kind of, that whole process is kind of behind us now. And the discussion going on is which one of those types of things will stay and which ones will go away. And it's my opinion, after talking to lots of people about what's going on here, is the things like the reimbursement, the elimination of anti-kickback and Stark law problems. I think these barriers are gone forever. The one which will probably remain and go back to the way it was is state licensure. So I think that state licensure will go back into place, but there are these compacts which are in the process of being adopted by more and more states, so that there's reciprocity, so clinicians in one state can practice in other states and stuff like that. So the point is that COVID, what happened was telehealth was the only way health systems could keep taking care of patients during the pandemic. And then now that people have gotten used to it, it's actually going to stay even in the post-COVID world, because it's actually easy to use and it's better for the patient and lowers cost. And the way I liken it is a little bit like, I think most, we're familiar with banks, how we used to have to go into banks to do any financial transaction. Now we pretty much do everything online, but we still need to go into banks sometimes to sign big loan docs or things like that. But this is actually now, healthcare is going to go through the same transformation, where there's going to be virtual care or telehealth systemically integrated into patient flow. What can be done virtually will be done virtually. What has to be done in person will be done in person. For example, surgery obviously is going to be continually done in person. It has to be. But what people believe, and this is just by a lot of sampling I've done, is that probably 30 to 50% of healthcare interactions between a healthcare professional and a patient can be done virtually. So that's going to fundamentally shift how our healthcare delivery system will happen in the post-COVID era. Well, another thing which is kind of interesting. So what happened during COVID is there are a bunch of unique workflows which had to be created for a health system. For example, it became very common for a health system or hospital to have a COVID ward. A COVID ward is obviously where they put all the COVID patients together. And then I think we saw on the news the whole personal protective gear, very expensive, very laborious to put on and off every time you go in front of a COVID patient. But now if you can, but there's a point in time when you put a telemedicine device in there and it allows the clinician to take care of the COVID patients, especially if it's a simple or easy question that needs to be asked. There, I already mentioned the desire at various times to keep patients and providers at home. I think that was accentuated last year during the spike of the pandemic, but even now, post-pandemic, it's highly likely that people are going to want to take care of the patients specifically at home as much as possible. The other thing which came up during the spike of the pandemic is, as many of you probably know, hospitals didn't allow any guests inside the hospital. So if you have a loved one who's going in for like a stroke, a heart attack, or even a baby delivery. My son actually had his first child during this pandemic, and it turned out they allowed the spouse, but nobody else to be in the room during the delivery. So those things you can bring in family and friends via telemedicine. So now we're in a period of time where we're starting to the equilibration process of how healthcare systems are going to work post-COVID. And as I already mentioned, a lot of people think 30 to 50% of care interactions can be done virtually. Just to put some specific numbers by it, pre-pandemic, 1% of interactions were virtual. During the height, it went to 52%. It's gone back down to about 20%, which is still a lot. 20% of all interactions with the healthcare system being virtual is still a pretty seismic change. And then how that moves forward and goes to probably a 30 to 50% rate is, I think, the path that we're on. So I'm part of Teladoc Health now, and just to give you the size and shape of an organization which does this, we'll do about I think about 13 million primary care kind of visits virtually this year. We'll probably do 4 to 5 specialty visits, and then we do a lot of taking care of people with chronic diseases like diabetes, hypertension, heart failure, remotely as well. And all this was accelerated by COVID. And then just kind of my last slide here is, so as I mentioned, so this area of virtual care can actually help with patient care anywhere in the continuum of the patient's journey, whether they're well, they want to stay well, whether it's like an annual checkup or something like that. Mental health is something which has gone kind of, become a pandemic in itself, and virtual care is something which is doing a great job in terms of helping address the mental health issues that our population has, and then all the way over to acute care, chronic disease management, specialty care. So there's going to be ongoing growth in this area of virtual care, and quite honestly, COVID really brought all of this capability forward. So with that, I'm going to stop and
thank you so much,
back to you,
Dr.
Nini.
Wang. So I have some really interesting questions. I think we'll start with Joe, because I think this is a question that's on everybody's mind, really, is, will we need a booster shot? And then I think that'll lead into a question for Justin, because it brings up the role of variants and whether we're going to need annual immunization, and as far as whether BioIQ plans on being able to continuously test for variants, even with a lower number of people transmitting and spreading the virus. So Joe, are we going to need a booster?
Yeah, You know, both the Pfizer CEO and the Novavax CEO said we will need boosters, and that is just to boost their stock prices.
I agree.
And that's that. The only honest answer to that question is not for 6 months. The boosters this fall, we won't need them. And we know that because the clinical trials are running about 6 months ahead of where we're at in population level vaccination. And the clinical trials have what's called a stage 4, right? Which means follow-up of those patients in the stage 3 clinical trial. So if we start seeing vaccine breakthroughs at a large number that's correlating with novel variants, which of course we aren't measuring well enough here in the States, but if we start seeing those types of breakthroughs at a larger number, then we'll need to start seriously thinking about booster shots. The good news is that both the mRNA vaccines, which to my mind are clearly superior at this point to the adenoviral vaccines, but both of those types of vaccines are quite flexible because they're using a synthetic bit of RNA or a genetically modified virus. You can just chuck in whatever new spike sequence has evolved. And what that would look like in the regulatory space, we're pretty sure it would be expedited, but exactly what it would look like, we're not quite sure. But you know, I think one of the hardest things as a scientist about this whole pandemic has been that a lot of times the only honest answer to a question is we don't know. But we do know that the likelihood of boosters in fall is, I would say, less than 5%. I think is probably not quite.
And we have T cells and B cells and all that good stuff too. So yeah. Justin,
go ahead.
I wanted to ask you to follow up that question. Will you be testing for variants going forward, especially if we don't have that many cases?
Yeah, it's a great question. So we currently do that. We have an offering where we can take positives and reflex test those. So if a test is in a lab and it's positive, they can take that same sample and put it on a next-gen sequencer and test the variant. However, the challenge is that testing in general is moving away from lab tests to rapid home tests, which means you're going to get a positive at home through a rapid home test. There's nowhere to send that sample to do variant testing. I mean, you can send the sample out, but it's a different test, it's a different cost, so it takes a big convenience factor. So despite the fact that that will improve testing, make it easier, less expensive, more convenient, it could actually bring down the variant testing because it's being done outside of a central lab. It's a challenge in how testing is evolving.
I have a question for Dr. Wang, and Joe and I had the same question, and it really is, how will telehealth meet like the needs of rural communities? Because I can imagine that there are areas, sometimes people don't know how to use the internet, or some parts of the country where access to telehealth is a lot more challenging.
Well, so I think just even access is hard, not only just in rural areas, but even in many kind of suburban areas. Actually, Justin and I have actually had conversations about how do you merge telehealth interactive capabilities with testing capabilities, because sometimes you need a clinical expert in addition to a test in order to help render a decision or opinion on what that person should do next. So I think telehealth combined with what Justin's organization is doing is really bringing a lot of what has traditionally needed to happen inside a hospital out into the community and the population, which is actually, it's got all the benefits of the easier access, the lower cost, et cetera. I didn't know, Justin just brought up a good point about kind of the variants requiring more sophisticated equipment, stuff like that, but you can still do a lot of stuff at home that you otherwise couldn't.
So I think a valid concern people have, and I think this is for both Dr. Wang and Justin, and as far as these digital platforms and having your access to your records, what is the risk with like hacking, right? And the privacy aspect of that, because we know nowadays that companies can be more vulnerable to these types of events. I know my company, Garmin, was vulnerable to it in the middle of like last summer. So how are you addressing that?
Justin, you want me to go first? You want to go first?
Yes, please. You guys deal with a lot of data.
Well, what we have to do is no different from what banks have to do, no different from what health systems have to do, et cetera. You have to stay ahead on the whole cybersecurity side, and that's a moving target. And so you're constantly improving the systems that you have, the encryption technology, the different methods that you do to detect anomalies, the training of your people, et cetera. There's no magic. And quite honestly, I don't think telehealth is any different from any of these other high consequent industries.
Yeah, I'd agree. There's HIPAA, there's high trust, there's some baselines, guidelines for companies in healthcare, but it's constant, never-ending investment. Like that's I guess that's our answer as well.
So something that I think we've all heard, this is for Joe, like at one point, people kept saying, oh, this is eventually going to become less virulent, like the trend. So how much truth is in that statement? Of course, over a long period of time, like, will it ever become like a flu?
The thing about evolution is you just can't predict an outcome. It's just not possible. Yeah, there's a general trend in virology that viruses over time co-evolve with humans and their immune systems to become less virulent. That typically comes from studies on viruses from many, many human generations ago, where there was no healthcare infrastructure, no intervention. And so the outcome was you either die of the virus or you don't. And so, human evolution takes generations. We don't want that to happen, right? We want to intervene and not have people have to die in order to live alongside COVID. And so in the short, medium, and long term, there's really no way to predict. There's only the possible outcomes we can explain to people. As you mentioned, it going endemic, I think, is probably the most likely at this point. We could also imagine a situation like measles, where you have it largely eradicated and it pops up here and there. We would have to take it would take a lot of investment and work to get there. I think the thing is, we have been at an inflection point, and we continue to be at an inflection point. And the virus is doing its evolution, and we're doing our biomedical interventions, and what path we end up on is actually still actively in our hands. And we can intervene, and we should continue to do all the diagnostics we can, and continue to work on treatments and how we treat people in hospitals. But the global vaccination is the way.
Well, thank you so much to all of our panelists today. And what we're going to do is we're going to move on to the Appreciate platform, and then we can mingle and continue to answer some questions. I just want to thank all of our panelists for being here today, and make sure that you sign on to Appreciate. You just have to click on the link, and hopefully I'll see you all there. Have a good evening.
Thank you so much, Nini.